Okay, chronic bronchitis. Okay, also in the class of COPD. Remember, COPD is a class with numerous disease processes underneath it. Okay, so chronic bronchitis is a chronic obstructive pulmonary disorder. This is chronic irritation or infection of the trachea, the bronchi, or the actual bronchioles found in our lung tissue. The problem with this is that we due to some kind of irritant, some kind of outside irritation that comes into our lungs, we start developing excess mucus production. That excess mucus production starts to line the insides of our bronchioles and our bronchi and our trachea, and this interferes with alveoli ventilation. Okay, this is not necessarily a respiration problem. There's no problem with gas exchange. The problem is getting air in and out of the lungs due to the mucus kind of plugging up the holes or closing up the holes that are important for us to get this air in and out. Okay, some of you might have had bronchitis. Okay, specifically you guys that live with people that smoke. Okay, this is the number one cause of bronchitis. Is actually from secondhand smoke. Okay, it can also be up there because of some kind of severe sinus infection. Okay, so for those of you guys that suffer allergies, whether it be in spring, summer, fall, whenever you guys are suffering allergies, and you start coughing up those nasty loogies, more than likely you might have a mild form of bronchitis. But everybody kind of gets bronchitis throughout their lives. It's not necessarily a medical emergency, unless we have some kind of severe bronchitis reaction, some kind of severe or acute bronchitis reaction, in which case they may need to get on antibiotics. They can be put on home oxygen for a little bit, along with some steroids that they'll be prescribed by their doc in order to help combat this. So people that suffer from chronic bronchitis a lot we call blue bloaters. You can see a picture of this gentleman here. His body looks blue. Okay, he has systemic cyanosis. All right, and again, we really do see true chronic bronchitis due to right-sided congestive heart failure. We talked about pulmonary edema. The number one cause was left-sided congestive heart failure. Well, now we have right-sided congestive heart failure, right? So when we're talking about the heart, remember it's a two-sided pump. They're both squeezing together at the same time. With the left side, we had damaged the left side of the heart, whether it be some kind of trauma or maybe we suffered from a heart attack. So when we damage the left side of that heart, the right side's pumping accordingly. The left side's not in sync with the right side, which means that the blood is going to back up into the lungs, causing pulmonary edema. With the right side, the left side is still squeezing appropriately, but the right side is damaged, right? Again, this can be caused from trauma, or this can be caused by a heart attack, or numerous heart attacks, whatever you guys want to put it at, right? So the right side of the heart is damaged because the blood returns to the body from the right side of the heart. If the right side is damaged, the blood starts backing up back into the body. You guys can see this gentleman's legs. They look like they are clearly bruised, okay? They're not. That is blood pooling because the right side of the heart is not pumping efficiently. So that blood is starting to pool down there, right? And it's not going back to the heart in order to get oxygenated. We'll talk about more about right-sided congestive heart failure when we get into our cardiac emergencies. So again, guys, chronic bronchitis causes, the number one cause is due to smoking, right? And really it's secondhand smoke, okay? This is really what kind of brings on the primary symptoms of chronic bronchitis, okay? So again, I'm not going to lecture you guys, all right? If you're smoking, please stop, okay? There's 6,000 different ways, 6 million different ways to die, I guess there is. You guys get to choose one. And I don't know about you guys, but look, I used to be a smoker. I love tobacco, right? I really do. I miss it so much. And every single time I see somebody smoking, it just makes me want to light up, right? But it's, man, who wants to die from shortness of breath, That's the way I see it, right? I want to die in my sleep. Quick, boom, right? Walk up, stand up, drop dead of a heart attack. Done. Life is over. Life is good. I had fun. I don't want to die over days or weeks or months due to the fact that I was sitting there smoking my whole damn life. To know for the basic levels, we do have our blue bloaters. All right, that's the big one. They do usually have a chronic rattling productive cough. It sounds like their chest is rattling inside there, and really it is, right? We have all this mucus production. They keep coughing up this nasty kind of uh, really thick phlegm. Okay, we could possibly have wheezing or coarse crackles, also known as rhonchi. And again, coarse crackles are kind of like that snap, crackle, pop. If they're really bad, it's like you guys putting a straw into a glass of water and starting to blow through that straw to create bubbles. I have heard some nasty rhonchi in my time, and I have heard rhonchi without my stethoscope quite a bit, to be honest with you. You can hear it as soon as you walk in the room. You can hear it when people are talking. Just their chest is rattling. And it's just because they have all this fluid in their lungs due to years of chronic toxic inhalation. Okay, so how do we treat it? Let's give them some oxygen. Once again, similar to what did we just talk about? Similar to emphysema, okay? Similar to emphysema, we just want to get them on a little bit of oxygen, okay? A nasal cannula for these people anywhere between 1 and 6 liters per minute does very good. Can really boost them up, can really make them start to feel better, all right? We might need to, if it's really bad, we might need to assist them with a BVM. I never truly have done that with a bronchitis patient. I've definitely done that with some kind of emphysema patient, right? I've never really had a true bad bronchitis management, and I think the reason for that is that specifically our area of the region, we are so dry out here that it kind of helps with putting the brakes on that mucus production. You know, again, a lot of these people don't really. A lot of these people really don't call 911 when it comes to this. This really isn't a medical emergency that we see a lot. Usually they just go to their primary care and urgent care, which can handle this just fine. But there are times that, yes, we may have to take them to the hospital in order for them to at least get maybe some kind of antibiotic treatment or something like that in order to help them breathe better. Let's go. Let's transport. Okay, we've already talked about that. If they are showing signs and symptoms of wheezing, let's give them some albuterol. We can even throw in some ipratropium with this as well. Make sure you guys are looking over your drug guidelines and your dosages for albuterol and ipratropium. Okay, moving right along into pulmonary embolisms, or what we call a PE. This is a clot that's developed in our veins, which then kind of travels up and gets lodged into our pulmonary circulation. Okay, most clots that develop in our veins kind of start in our legs. They're known as DVTs, or what we call deep vein thrombosis or thrombis. Okay, when you hear the word thrombi, it's just talking about a clot. And because of A, gravity, and B, medical conditions, specifically if the patient has caused damage to their heart, it might be hard for them to actually get the blood back up from their legs into the heart. It takes a little bit longer, specifically with like a right-sided congestive heart failure or something like that. But really these veins, or these clots develop in the veins, usually down the legs. Those clots get bigger and bigger and bigger. They get dislodged and they kind of start traveling up through the body. If the clot lands in the heart, more than likely we're going to have a heart attack. If the clot lands in the brain, more than likely we're going to have a stroke. If the clot lands in the lungs, ding, 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 we have just developed a PE. Okay. It's usually where that clot gets lodged in the pulmonary circulation. Because of this, the blood cannot reach the affected part of the lung in order to be able to oxygenate. Okay, which also means that the actual lung tissue, is not able to oxygenate and is starting to become necrotic. We're starting to kill off that tissue. Okay, these can be rapidly fatal. Okay, rapidly fatal. And really, the only way to diagnose this is by getting a true, good history on our patients. We're going to talk about that here in a minute. Okay, so there are quite a few risk factors for a PE. Okay, the big one is a recent surgery. All right, anybody that has had recent surgeries, complaining of shortness of breath, and they can say they have pinpoint chest pain. Okay, that's pain that stays in one specific spot in their chest, and you're going to ask them, right? So are you having chest pain? They're going to say, yeah. And can you point to it? And they can literally take their finger and they're going to point right where the actual clot is in their lungs. It goes nowhere. There is no radiation. It's not going up to their jaw. It's not going down their legs. It's not shooting to their back. It's right where they're pointing. Okay? Recent surgery specifically are older populations with like a hip surgery or a knee replacement surgery, something like that, right? They maybe weren't properly medicated while they were in the surgery, right? And they just happened to develop a clot, and this clot went straight into their lung. Okay, people on bed rest, right? Again, any patients that have history of bed rest, right, can develop a PE. Any kind of broken long bone, specifically the femur, okay, or the pelvis, right? Any kind of long bones, any kind of major bones where they have had surgery on, they could develop a clot. They kind of screwed up their clotting factor while they were actually performing the surgery in the first place, and they develop a clot, and this thing travels up to their lungs, and it lands there, and all of a sudden they just have this sudden onset of shortness of breath. All right. Long sitting trips, again, specifically with our geriatric population. Now, this can happen to anybody. Okay, I don't want to pick on the old people, right? This can happen in kiddos for some reason. This can happen in adults. It's rare for kids. It can happen in adults, but if you guys are sitting for really long, specifically on flights on airplanes, right? You guys are taking that, maybe 8, 9, 10, 15-hour flight wherever, right? Or you guys are driving across country or something like that, and you're not stopping to kind of get out and kind of stretch your legs and walk around, you could definitely develop a pulmonary embolism eventually. Cigarettes, guys, again, right? Cigarettes screw with all kinds of different clotting factors for us, and we could definitely develop a pulmonary embolism with that. And then for you females and males, I guess, nowadays, but mostly for the females, birth control. Birth control really kind of screws with your clotting factors, and you can develop more clots than normal on birth control, and those clots can obviously lead to a pulmonary embolism. So pulmonary embolism signs and symptoms, this is usually a sudden onset of respiratory distress, right? They're sitting there chilling, nothing's really going on, and all of a sudden they cannot catch their breath. Okay? However, there is no difficulty with them ventilating. Okay? This is not a problem with air getting in and out of the lungs. This is a problem with the actual diffusion of gases. This is a problem with the pressure gradients that we need in order to diffuse gases, offload that CO2, unload that oxygen, because part of the lung is not being perfused itself. Okay, because of this clot, we have basically tourniquet, probably some part of the lung where that blood is no longer going to, right? And we're going to start killing off our lung tissue. Okay, here's the other thing. You guys can have completely normal breath sounds. Okay, again, this is not a problem with ventilation. This is not a problem of air getting in and out of the lungs. This is a problem with respiration. This is a problem with gas exchange. This is a problem with the fact that we have a clot in our lung. We have a clot in our vasculature, right, that is prohibiting blood flow to a certain area. Okay, if we are prohibiting blood flow to that certain area is starting to die. That certain area is not available for gas exchange. Okay, that certain area is not able to offload CO2. That certain area is not able to onload oxygen in order for the body to use. Okay, they usually are hypoxic. Okay, and it develops quickly. This usually is, you guys might start running on this patient, they might be at 85%. Okay, and let's say you guys throw them on a non-rebreather first, right? Let's say at 10 liters per minute, and nothing changes. So you bump it up to 12 liters per minute, and nothing changes. And then you bump them up to 15 liters per minute, and nothing changes. Okay, it's not going to change. All right. Again, we have a clot. We have a blood clot in our vascular. We're not able to get blood into that area for gas exchange. Okay. So you're not going to get readings on oxygenation. Okay. It could be a sudden, sharp chest pain. And again, I want you guys to write this in your notes. It's a sudden, sharp, pinpoint chest pain. They could take one finger and point directly on their chest where this pain is, and that pain stays there. Again, it doesn't go up their neck. It doesn't go down their arms. It doesn't shoot to their back. It is boom, right here. And they are literally pointing right where that clot is in their lung. Okay? And then we could also have signs and symptoms of shock. They could be extremely tachycardic. They can have an elevated heart rate, right? Because the brain is trying to perfuse as much as possible, so it's going to blame the heart first. Because they think that the brain thinks that the heart's being lazy, so it's going to tell the heart to speed up in order to try to perfuse all the cells within that system. And then we could also have what's known as JVD, or jugular vein distension. Okay, and I'm pretty sure I have a couple of videos for you guys on JVD, or a couple pictures. If not, Google it. Okay, guys, I'm pretty sure you have a couple of those in your shell. Along with a video of an actual pulmonary embolism being removed, or what we call a saddle embolism. And if you guys are having problems looking up that video, Google it as well. Just look up saddle emboli, or saddle like a horse saddle, pulmonary embolism. You guys will be able to see that. So what can we do at the basic level? We're going to assure adequate oxygenation and ventilation. Okay, we want to make sure that our patients, even though they are breathing correctly, we want to try to saturate those red blood cells with as much oxygen as we can. So we're going to throw them with that non-rebreather at 15 liters per minute. There may be the opportunity specifically for the pulmonary embolisms where you guys are going to have to assist their ventilations. Okay, but let me explain something to you guys. Okay, us and EMS in general, it doesn't matter if you're basic, AEMT, advanced EMT, paramedic. There's really not much we can do for this. This patient needs to get to the hospital. This patient needs surgery at some point, okay? Or maybe some kind of thrombolytic therapy, some kind of medication that they can use to thin their blood. It all depends on the people that make a lot more money than we do, okay? So let's take them to those people that make a lot more money than we do. Okay, let's not stay and play on scene. Let's help spread the liability for the people that make a lot more money than we do, and let's get them to the hospital in order for them to help our patients out. But in the meantime, let's give them some oxygen, high flow oxygen, non-rebreather, anywhere between 10 to 15 liters per minute. All right, let's put the patient in a position of comfort. They might get a little anxious on you. Okay, they don't know why, right? But they do have a history. They might have a history of that long vacation, that long airplane ride, that long road trip, right? They might have just had surgery on something. They might be a female that's smoking and on birth control, okay? Like two of the worst things you could put together. It just depends, okay? Either way, high flow oxygen. Let's get them to the hospital. You're more than welcome to consider ILS, ALS intercept on this. But again, I want you guys to know that's really only if you guys need a second set of hands. All right, specifically if you have to start BVMing your patient, if you have to start bagging, if you have to start providing that positive pressure ventilation, you're going to need an extra set of hands. Okay, but if that patient's stable enough where they're kind of feeling a little bit better on that non-rebreather, just get them to the hospital. Okay, probably the most common 911 call that we get is for hyperventilation, usually due to some kind of stress or anxiety. okay, or what we call a panic attack, right? It is a very excessive, deep, and rapid ventilation. Okay, the problem with this is that we are blowing off too much CO2. Okay, they can experience what's known as syncope. Syncope is just a sexy term for fainting, guys. Okay, if they are hyperventilating and they do get to the point of actually passing out because they're hyperventilating, think of that as like the brain's control alt delete. Okay, it's the brain resetting. Okay, usually when they are hyperventilating, we're talking about respiratory rates in the 30s, maybe even possibly the 40s. Okay, after a while, the brain's going to say, hey, this ain't happening. I'm turning everything off. I'm going to shut everything down. Boom, patient passes out on you. They faint. They become unresponsive for a little bit. They wake back up, and usually they have reset their system and they are not hyperventilating anymore. Okay, you guys will definitely experience this at some point in your careers. I've experienced this a couple times in mine. I've had people that have passed out and woken up and gone straight back into a hyperventilation. All right, this, when we're doing hyperventilation, we want to try to just reassure our patients. We want to do a lot of therapeutic communication. We actually want to try to get in their face, make that eye contact with this patient, and teach them how to breathe. Show them how to breathe. Okay, let's see if we can start with that in order to try to get their respiratory rate down to a normal level. All right, so signs and symptoms, they're usually in a panic or pretty excited. Okay, they could be agitated, they could be restless. This is where you guys have to get up in their face, make eye contact with them, assure them that everything's okay, and start showing them how to breathe. Okay, they will more than likely have clear breath sounds. They can get numbness or tingling in their lips, hands, and feet. And there are such things called carpal, which are hand spasms, or pedal, which are foot spasms. All right. This is because they're blowing off too much CO2. And it's actually that their hands will actually, if your hands are on your side, right, and you guys are breathing normally, everything's good, but your hands will actually start to, you won't be able to bend your fingers. They kind of look like they're this crazy like stretching of the fingers, and the hands will kind of start contorting inwards into the body because they're blowing off too much CO2. Make sure that you guys look that up. Carpal pedal spasms, there's some great pictures of those on the internet so that you guys can kind of see what I'm talking about there. And if they're breathing really fast for really long and they're blowing off too much CO2, they can actually develop a sharp chest pain. All right. Again, this is usually because their muscles are starting to become tired. They're burning a little bit too much energy. They're actually starting to develop a cramp in their intercostal muscles. That's usually what the actual chest pain is from when it comes to hyperventilation. So, how do we manage hyperventilation? Again, before we do anything, all right, we want to see if we can coach the patient's breathing down. Okay, don't take a lot of time with this. All right, but let's dedicate at least a couple minutes to see if we can get them to calm down that way. Okay, we do want to consider a pulmonary embolism. Again, we plan for the worst and we hope for the best in EMS. Okay, the initial presentation can look similar. All right, so again, we want to try to do our best to get a good sample history. But at this point, specifically when somebody's hyperventilating, let's try to keep it to yes or no questions so they don't have to elaborate too much. Okay. Sure, we could try to put them on some oxygen. I think a non-rebreather at 15 liters per minute is overkill. I would start off with a nasal cannula, maybe at just a couple liters per minute, and still continue to try to coach their breathing down. Okay. Coach the patient. Coach the patient to slow their breathing. Tell the patient, look, if we can't get you to slow your breathing down, there is a good chance that you are going to pass out. That's okay. It's a normal response. Okay? Be patient advocates, guys. Let the patient know what's going on with them. Okay? If they pass out, just let them know, hey, everything's going to be okay. I'm going to be right here for you. You'll wake up after a little bit, and hopefully this all kind of goes away. All right? We do want to try to advocate for these patients to go to the hospital. And there's a couple different reasons why. There could be some kind of underlying condition that we don't know about, okay? That they might have to get blood work for, or chest x-rays or something like that, considering the PE, right? We can get them to counselors, right? In order to try to get them ways to better cope with stress-related factors, or stress that might be going on in their lives. Some coping strategies in order to help them out, so that we don't have to run on them again if they do go into a hyperventilation. They may be able to help themselves instead of having to call 911.